Hello everyone. Very good evening to all of you. I welcome you all for today's session and I welcome the batch third Prof 1.0. In today's session, we are going to study community medicine. And in community medicine, we are going to start the most awaited topic, that is non-communicable diseases. We have already completed 40 communicable diseases till now, and now it's time to study the non-communicable diseases. So I'm going to teach you non-communicable disease in a unique way, that's Masterchart. Most of you are already aware the way I teach, that is Masterchart. So I will teach you 7 non-communicable diseases in the form of comparative tables under a fixed set of heading with multiple images, videos, and that will be Masterchart. So let me share my screen with you and start the session. I guess you all can see the screen. So let's start it. So as I told you, in this batch, the third Prof 1.0, today's subject is community medicine. And today, in community medicine, we are going to study non-communicable diseases. So before I start non-communicable disease, can any one of you tell me the definition of communicable diseases? We have already completed communicable disease. What are communicable diseases? So non-communicable disease will be opposite of that. First, revise what is communicable disease. So this is communicable disease. Communicable diseases are the diseases which are transmitted from person to person. So communicable diseases are the diseases, which are caused by one of the 4 microorganisms, that is either by bacteria or virus or parasite or fungus, and they are transmitted via 3 routes. Either they are transmitted from man to man or animal to man, that is zoonosis, or environment to man. So this is communicable disease. So basically the word indicate communicable. The communicable diseases are the diseases which are communicable in nature, that are transmitted either man to man or animal to man or environment to man. So I already taught you 40 communicable diseases in our syllabus under a fixed set of heading, Masterchart. I hope your master charts of communicable diseases are ready. If they are ready, of all the 40 communicable disease, kindly take a photo and send it to me. So I taught you all communicable disease under these headings. These are my fixed heading for communicable disease. Now, today I'm starting non-communicable diseases. The non-communicable diseases are known as NCD, non-communicable diseases, NCDs. They are known as NCDs. So I am going to teach you 7 NCDs. They are in front of you under a fixed set of heading. So what you are waiting for? Take out your notebook, take out your pen right now and start filling this master chart with me right now. I will be teaching you coronary artery disease, rheumatic heart disease, hypertension, obesity, diabetes, blindness, and cancer under these headings, under a fixed set of heading. That is introduction, pathogenesis, risk factor, clinical features, and prevention. The most important among them is to understand their risk factors. If you understand their risk factors, you will be able to write the prevention. What is the subject I am teaching you right now? I am teaching you preventive medicine. So you all can understand in preventive medicine, the most important aspect is prevention. Preventive medicine. The most important aspect in all these non-communicable disease is their prevention. So to understand the prevention, you have to understand their risk factors first. I hope you are getting it. So this is the master chart. But before I teach you all these one by one, I will be starting these one by one. And I will be teaching you all these with many images so that it imbibe in your mind. Before that, I would like to give you overview of overall communicable disease. Overall, I will start these one by one. But overall communicable disease, first we will see an overview. Then we will start these 7 diseases one by one. So tell me the introduction. What are non-communicable disease? What are NCDs? NCDs, non-communicable diseases. What are? Define them. So non-communicable diseases are the diseases which are not transmitted by people, vectors, or objects. You can see. So I have put a cross over here. I think you all can see this cross. They are not transmitted from person to person. They are not transmitted from animal to person. And they are not transmitted from objects or environment to the person. So they are non-transmissible. That is the meaning of non-communicable. So these are the diseases, the non-communicable diseases are the diseases which are not transmitted by people, vector, and objects. They are also known as chronic emergencies. They are a sort of emergencies. I will let you know why they are emergencies, because their incidence and prevalence is rising drastically nowadays, and nowadays they are replacing the communicable disease. So they are chronic emergency, and they are also known as lifestyle diseases, because in most of them, the pathogenesis, the culprit, the risk factor are the modern lifestyle which the humans are adopting. So learn their other name, non-communicable disease, NCDs. also known as chronic emergency. They are also known as lifestyle diseases. So that's the introduction. So what we have learned in the introduction, what are non-communicable diseases? Non-communicable diseases are the diseases which are not transmitted from person to person, animal to person, or environment or object to person. They are not transmissible. They are also known as chronic emergencies, and they are also known as lifestyle diseases. So that's the introduction. Now, what is the disease process? How does they start? How does they progress? How does they end? What is the end result? So all NCDs start in the body of the human without knowledge. The person is not aware. For example, let's take a chronic disease like non-communicable disease. Let's take atherosclerosis, okay, CAD, or coronary artery disease. You can see here it already started. The atherosclerosis already started, but person is not aware that there is atherosclerosis inside me. They gradually progress over the time. They are very slow in progression. They take years and years to progress, but person is not aware. You can see years and years to progress. So they are very slow. They start without knowledge. Okay, they grow very gradually, slowly inside the body. Gradually they are growing. Okay, they finally leads to structural impairment, functional impairment of the organ. Now, this is the heart. The coronaries is having atherosclerosis. So they will lead to structural and functional impairment. Then the person will have the symptom. Then the person have chronic disability. Chronic disability. The person will have chronic disability and a chronic disease throughout the life. They lead to chronic disease. The chronic diseases are throughout the life. They are not curable. They are throughout the life. Okay, they are of long duration. So that is the course. So they start without knowledge. They gradually, slowly progress over the time. Then they do structural changes in the organ. Then they do functional changes in the organ. Then person came to aware that I'm having some chronic disease. And ultimately it leads to chronic disease throughout the life. So this is the course of the NCDs. I hope you are getting it. So introduction is done. Disease process is done. Now coming on the types of NCD. How many types of NCDs I'm going to teach you? So there are two types of NCDs, major and minor. The major one are these. There are 7 major NCDs. I'm going to teach you all 7 in detail. Coronary artery disease, rheumatic heart disease, and hypertension. These 3 together known as cardiovascular diseases. If you're getting a long question in your university exam on cardiovascular disease, you have to write down all 3. But usually you get the question on one of them. Long question on any of them. Coronary artery disease, rheumatic heart disease, hypertension. These 3 together known as cardiovascular disease. Apart from that, I will be teaching you obesity, diabetes, blindness, cancer. So these all are asked as a long question in your university exam. So if it is coming as a long question, you have to frame your answer under a fixed set of heading. I will let you know. Okay. And if it is a short question, you have to write down only the preventive portion of these. The prevention of these is most important. You can see these 7 I'm going to teach you in detail. I will be teaching you coronary artery disease, rheumatic heart disease, hypertension, obesity, diabetes, blindness, and cancer. I will be teaching you these 7 in detail. These are the minor one. Okay, the renal disease, mental disease, nervous disease, respiratory disease, hormonal disorders, musculoskeletal disorders, degenerative disorders, autoimmune disorders, allergic disorders, and accidents and malnutrition. These are minor. I mean, you have already studied all these in the pathology in various subjects. You are aware of these diseases, but here prevention don't have much role. The prevention is having much role in these. So the major one we are going to cover in detail. In our syllabus, we are having the major one. These are the 7 major NCDs I'm going to teach you in detail in this session. You can see these 7. And this is the fixed set of heading under which we are going to cover them. So you can see 1, 2, 3, 4, 5, 6, 7. The 7 NCDs we will cover under a fixed set of heading, and this is Masterchart. So please don't waste your time. Take out your notebook and pen and start filling this with me right away. Right now you have to fill it with me. Chalo. So that is the types of NCDs. Now why the NCDs are gaining importance nowadays? Nowadays the NCDs are gaining much importance. There are 3 reasons. Nowadays they are replacing the communicable disease. Previously, the communicable disease were the main disease that is of main concern for the mankind. But nowadays, because of improved sanitation and all hygiene, the communicable diseases decline, but the non-communicable diseases are increasing in trend. They are becoming the most common cause of disability, morbidity, and premature mortality. They are the most common cause of disability, morbidity, and premature mortality. And they are doing epidemiological transition. This is known as epidemiological transition. Because of this, the NCDs are gaining importance nowadays. What do you mean by the transition? There are 2 types of transitions associated with NCD. What are the 2 types of transitions associated with NCD? Number one, demographic transition. Demographic transition means nowadays the aged people are more in population. In the overall population, if you see total population, the percentage of aged people are gradually increasing because of the non-communicable diseases and their control. The control of non-communicable disease. The aged people population is increasing because of the non-communicable disease. And social transition. Nowadays, the smoking, alcoholism, junk food, their trend is increasing. That is modern lifestyle we call. And because of which, the non-communicable diseases are increasing. The incidence and prevalence of non-communicable diseases are increasing because of lifestyle modification. Smoking, alcoholism, unhealthy diet, junk food, that is known as social transition. So this is demographical transition. This is social transition. Because of non-communicable diseases, there are two types of transition. The demographic transition, in which the aged population is increasing. The percentage of aged population, old people are more in the entire country. And social transition, all the lifestyle modifications, that is smoking, alcohol, inadequate or unhealthy dietary habits, they are increasing nowadays. This is social transition. So we are having demographic transition and social transition. These are the two transitions associated with NCD. Okay, now what is the impact on the health system because of NCDs? Because of NCDs, there is increased burden of treatment, care, and long-term support. As I told you, because of the NCDs, the percentage or the proportion of the old people, disabled people, the people with chronic diseases increased on the earth. And that's why the cost of treatment is more, the cost of care and the long-term support is more. Initially, we don't treat non-communicable disease, we don't prevent, we don't treat. And that's why the person who are having all these diseases get dead. But nowadays, because of better prevention and better control and better treatment, the percentage of the people who are having non-communicable diseases is rising. And that's why it is overall impacting the health system. Okay, it is increasing the burden on the health system. What are the characteristics of NCD? Can you enumerate the characteristics of non-communicable disease? NCD. What are the characteristics of NCD? These are the characteristics. They are very slow. They are very slow. Okay, they last for long duration, for years, without being awareness. The person is having these NCDs, but the person is not aware for years and years that I am having any of the NCD. They are very slow in progression. Number two, they cause disability. They cause disability to the person, disability to organ, disability to function, and they require long-term treatment, very long-term treatment for years or maybe throughout the life. They result in financial burden. For example, you can take the example of diabetes. You can take the example of hypertension. How many of you have the patients of diabetes and hypertension in your family, your parents, grandparents, or any of your relative or your known person? I guess many of them. Okay, maybe few of them. They are having diabetes and hypertension. They are the chronic diseases. They are non-communicable diseases. Okay, so the treatment is lifelong. They have to take the treatment lifelong. It is not like a course of antibiotic for 7 days, for 10 days. They have to take and the disease will be cured. These are non-curable disease. Once diabetes happen, it will be forever. Once hypertension is set, it is forever. So lifetime treatment is required or modification is required. Yes or no? So it increases the financial burden. That's the meaning. It needs the family involvement for holistic support, you can see. And it sometimes results in premature death. So these are the characteristics of non-communicable diseases, NCDs, you have to learn. Okay. Now what is the global burden and India burden? You don't have to learn the figures. Just for your knowledge, I have given you the figures. This is the global burden. Okay. Total NCD, the death due to NCD in 1 year. In 1 year, how many people die due to NCD? 36 million. 36 million is a big number. In the entire world, 36 million people die in 1 year because of NCD. You don't have to learn the figures, but just for your knowledge, you can see the figures over here. What is the Indian burden? Indian burden. Contribution of total disease. They constitute 62% of the total disease burden in India. 62% is a big percent. The total disease burden. The 62% of them is only NCDs. So you have to see just these figures. You don't have to learn them. So that is the burden, global burden and India burden. Okay. Now, the most important thing before I start the details is levels of prevention. How many levels of prevention are there? I already taught you levels of prevention in a separate video. Here we will quickly revise it. There are 4 levels of prevention. Okay. For all these non-communicable disease, I will be teaching you 7 non-communicable disease one by one. I will start them. But before that, you must understand the overview of prevention. You must learn the prevention of these 7, how to prevent them. So overview first we will see. Prevention. There are 4 levels of prevention. What are the 4 levels of prevention? Primordial, primary, secondary, and tertiary. These are the 4 levels of prevention. You can see the 4 levels of prevention: primordial prevention, primary prevention, secondary prevention, and tertiary prevention. The 4 levels of prevention. What do you mean by that? We will understand with the help of an example. Can you see? Can you see this example? I already taught you this example. We will revise it. See, this person is absolutely healthy. Healthy life. No disease. Healthy life. It's normal life. Okay, now this is a child. The child become adolescence, and at adolescent age, he started smoking. But he don't have lung cancer. We all know smoking leads to lung cancer. But he started smoking. So risk factor. So smoking leads to lung cancer. In this, the smoking is a risk factor and the lung cancer is a disease. So the risk factor is leading to the disease. Which is the risk factor? Smoking is the risk factor. And is a risk factor for which disease? It's lung cancer. So here the risk factor is present, but disease is absent. Till now the risk factor is present, but the disease is absent. The person started smoking, but person don't have lung cancer. Okay, now the persons have the lung cancer. The person is continuing. After few years, the person have the lung cancer. So here disease, but still it is an early stage. The disease is present, but it is in an early stage. If the person is not taking the treatment, it will become metastatic. It will become advanced stage. So here the disease is present, but it is an advanced stage. And finally, it will lead to disability and morbidity. So at what level we can prevent it? First, you tell me this is normal life. Okay, normal life means no risk factor, no disease. Here, I will say risk factor is present, but disease is absent. Here, I will say risk factor is already present. Here, disease is also present, but in early stage. Okay, here I will say risk factor is also present, but disease is also present, but in late stage. And here I will say already disability and impairment. Disability already happened. Now at what level we can prevent it? The best is we can prevent it here before the development of risk factor. Okay, so what if I will counsel my child? My child is 5-year-old. What if I'm counseling my child ki yes, beta, you don't smoke. But in future also, once you grown up now, you don't smoke. You never smoke in your life because smoking is a very bad thing. Smoking causes number of diseases. Okay, and it's a type of addiction. So you never smoke in your life in future once you become grown up. So child don't smoke, we know. But in future, we are doing the counseling in such a way from the childhood only. So that in future, once the child become grown up, he don't even think of smoking. Because from the childhood only, we are imbibing this in the mind. So risk factor is absent and we are eliminating the possibility. We are eliminating the possibility that in future also it will come. So this is known as primordial prevention. So this prevention is known as primordial. Primordial prevention is the best prevention. We take the action before the risk factor develop. Disease to absent here, there is no disease, but even before risk factor, we are taking the action. You are getting my point. Got it. Now here the smoking already started. Suppose it is an adolescent who is smoking, but lung cancer is not yet developed. So we can take the action over here. We can counsel this adolescent. Beta, you are a young one right now. You can quit the smoking very easily. You know, if you keep on smoking, maybe after 10 years, 20 years, if you keep on smoking, there are many diseases you can have. The benign one, you know, emphysema, chronic bronchitis, or the malignant one. They are deadly diseases. You should quit it. Okay, so we are taking the action after the risk factor, but before the disease. This is known as primary prevention. So risk factor is present, but still disease is absent. Second best prevention is primary. What if the person have not followed your commands, not followed your advice, and the person already have the lung cancer? Maybe this person was 15 years old and now the person is 25 years old. And 25, he developed the lung cancer. So we will advise, we can take action at this. Okay, you already have the lung cancer. Chalo, it's okay, but now you take the treatment immediately. You do the diagnosis and treatment. So this is secondary prevention. The disease is in early stage now. So we want to halt the disease. We want to halt the progression of the disease in early stage so that the early stage disease do not convert in advanced. So we are taking secondary prevention. Secondary prevention is taken when the disease is in an early stage. Once the disease is already advanced, we can't do anything now. We have to do just tertiary care. Tertiary prevention. Tertiary prevention is rehabilitation. We will just do the rehabilitation, prolong the life. That's it. So the 4 levels of prevention are in front of you. The best example I always give: primordial prevention, primary prevention, secondary prevention, tertiary prevention. Primordial is taken before the risk factor. Okay, primary is taken after risk factor but before disease. Secondary is taken after disease but in early stage. Tertiary, once the disease is in late stage. So the same thing is written in front of you. There are 4 levels of prevention. You can see the same. Primordial, primary, secondary, tertiary. You can see when primordial, when primary, when secondary, when tertiary. You can understand it. So in primordial, we are taking the action before the risk factors develop. Okay, like counseling a 5-year-old child that you don't smoke right now. We know. But in future also you don't smoke. So we are eliminating the possibility of development of risk factor in future. So before the risk factor, we are taking the action. Primary में person already smoke but don't have the cancer right now. So we are counseling to remove the risk factor. We are controlling the risk factor. So we are taking the action after risk factor but before the disease. Okay, secondary में disease is already present. So we are preventing the progression of the disease into late stage. We are halting the disease in early stage. So that's secondary. And tertiary में the disease is already in advanced stage. So we are just doing disability limitation and impairment limitation. That's it. So these are the levels of prevention that will be applicable for the various types of NCDs I am going to teach you now one by one. I guess you all are oriented now and now you are ready to fly. You got the overview of NCDs, the non-communicable diseases. I taught you the introduction, disease process, types of NCD, why NCDs are gaining importance nowadays, what are the associated transition, what is the impact on the health system, what are the characteristics of NCD, global burden, India burden, national burden, and finally, most important, I must say, is the levels of prevention. Okay, now let's start it. As I told you, I will be teaching you 7. You can include diabetes also. Here, diabetes I forgot to write. So diabetes also. So 7 NCDs I'm going to teach you. You can see these are the 7 under a fixed set of heading. People, please be ready with your master chart. Again and again, I am asking you to do the same thing because it is very important. If you make the master chart, you can revise the entire chapter just in 15-20 minutes or maximum half an hour. But if you are not making this master chart, you keep on flipping the pages, and retention will be poor. You won't be able to revise it properly. So make these compact versions. That's master chart. If you want the master charts from my side, I'm also preparing it. It will be available soon on our website, but it will take time. Okay. Meanwhile, you can make your own. The best is you can make your own in your own handwriting. And I'm very happy. There are many students who are following my instructions and daily they are sending me the photographs of their homework. They make the master chart in all subjects. I instruct you like this. They make the master charts and they send the photographs to me. And I feel very happy and blessed that you are following my instructions. And you will also, one day you will realize that it was very useful. Okay, chalo. So let's start these 7 non-communicable disease one by one. Let's start with the first one. Can I start with the first one? Coronary artery disease. The first 3 are cardiovascular disease. Okay, coronary artery disease, rheumatic heart disease, and hypertension. These 3 together are cardiovascular disease. Okay, so let's start with the first one. The first one is the coronary artery disease. Let's start with the coronary artery disease. Can I start? Let's start the coronary artery disease under these headings. Coronary artery disease. Tell me the introduction of coronary artery disease. What is coronary artery disease? I guess everyone know. The coronary artery disease arises from the imbalance between the supply and demand of the heart. Can you see this is the heart? What is the supply of the heart? What is the demand of the heart? Can you see this is heart? I guess everyone can understand this cardiac cycle. No need to explain. You can see the left side of the heart. Where is the left ventricle? This is the left ventricle. Can you see this is left ventricle? When the left ventricle contract, the oxygenated blood, the pure blood come in the aorta. And via aorta, the pure and oxygenated blood is distributed in all the organs. Okay, all the organs utilize the oxygen. Okay, so pure oxygenated blood convert into impure non-oxygenated blood that is collected by the veins. All the veins in the body are drained in SVC, IVC, inferior and superior vena cava. I guess everyone know. So SVC and IVC drain them into the right side of the heart. So right side contain impure blood. So right atria, you can see from the right atria, the blood goes to the right ventricle. From the right ventricle, it will go to the lungs via pulmonary artery. The lungs will purify it. Okay, the lungs will purify the blood. And again, the pulmonary vein carry the pure, oxygenated, purified blood to the left side of the heart. And the cycle is repeated. I guess everyone can understand this. Now, the question is, I am teaching you CAD, coronary artery disease. My current topic is coronary artery disease, CAD. Okay, which arise because of the imbalance. Imbalance between what and what? Between the demand and supply. Between the demand and supply of the heart. You will say, what is demand of the heart? What is supply of the heart? Now you tell me when the left ventricle is pumping, what is happening? Left ventricle pumping is important. Of course, it's important. If the left ventricle will not pump, we all will die. So left ventricle pumping is important. The heart pumping, the left ventricle systole, the left ventricle pumping is important. The left ventricle systole is important. When the left ventricle is doing the systole, the pure oxygenated blood come in the aorta and all organs from head to toe, all the organs receive pure and oxygenated blood. Yes or no? Yes or no? So this is how the left ventricle pump. You can see both the ventricles pump. Currently, I'm interested in left ventricle pumping, but both the ventricles are pumping like this. But have you ever thought from where the left ventricle is getting energy to pump? Left ventricle is pumping now. This is how the left ventricle is pumping. You can see this is left ventricle. You can see the wall of the left ventricle. See, this is the wall. The left ventricle pumping. You can see the wall is doing the contraction, doing the systole. But from where they get the oxygen to contract? They also need the oxygen now. They also need the pure blood. When the left ventricle is doing systole, the complete body get the oxygen. But who gives oxygen to the left ventricle? Who gives pure blood to the left ventricle? It's the coronary artery. Who is giving it? It's the coronary artery. Now see the same diagram again. Can you see the same diagram? So see the left ventricle. Everyone focus on the left ventricle. From the left ventricle, can you see the aorta is coming out? Yes, this aorta is coming out, this red color. Can you see this is aorta? Aorta is coming out. From the aorta, you can see I have drawn the purple color arteries. Can you see these purple color arteries? These are coronary arteries. They supply pure blood to the wall of the left ventricle. These are coronary arteries. What these are known as? Coronary artery. They are the branches of aorta only. So heart gives pure blood to complete body via aorta, and heart also withdraw proportion of that via coronary artery. I hope you are getting it. So coronary arteries are very important. They give blood to the heart. So this is supply. Okay, this is demand of the heart. This is demand of the heart. So heart is demanding the blood via coronary artery. If you fulfill the demand, heart will get the energy from this. Heart will get the oxygen. Heart will get the energy, and heart will contract. The left ventricle will contract, and it will supply the blood to the aorta. It will supply the blood to all organs via aorta. So if you fulfill the demand, you will get the supply. If you want the left ventricle to keep on contracting like this, if you want the left ventricle to do the systole, you have to keep coronary arteries patent, and you have to give the blood to the left ventricle via coronary artery. So this is the demand of the heart. If you fulfill the demand, the heart keep on giving the supply. So heart keep on giving the supply. So understand, this is a supply. The supply will be only if you fulfill the demand. I hope you got the balance. So till the balance is okay, you know the coronaries are patent. The coronaries are patent. They are giving the blood to the left ventricle, and left ventricle keep on contracting. But what if the coronary get obstructed? Have you ever thought if the coronary have atherosclerosis and coronary got obstructed? Can you see this is coronary, the purple color coronary. What if the coronary get obstructed? What if the coronary get obstructed? Tell me, if the coronary get obstructed, you are not fulfilling the demand. Okay, so if you are not fulfilling the demand, there will be imbalance. You are asking for the supply. You want the heart to contract, but you don't give the energy to the heart for contract. So how the heart will contract? If you want the heart to contract, the left ventricle to contract, you have to give the coronary blood. If coronary blood is less, it is 0 or less, heart will stop contracting, and that's the coronary artery disease, because it occurs because of obstruction of the coronary. I hope you are getting it. So how many type of coronaries we have? So before we enter in coronary artery disease, the name itself is coronary artery disease. You have to understand coronary arteries. How many type of coronary arteries we have? There are 2 type of coronary arteries. What are the 2 type of coronary arteries? Left coronary artery and right coronary artery. The 2 coronary arteries is left coronary artery and right coronary artery. The left is further of 2 types. Left ascending, left anterior descending and left circumflex. These are the 2 branches, left anterior descending and left circumflex. And right don't have any branch, it is known as RCA. So there are total 3 coronaries, LCD, LCX and RCA. And you can see they are supplying the complete heart. You can see which artery is supplying. Okay, you can see the LAD is supplying the anterior wall. LCD is supplying the lateral wall. And RCA is supplying the posterior wall. The medial wall is supplied anterior 2/3 by LAD and posterior 1/3 by RCA. So you can understand, although it's not important over here, it is important in anatomy or pathology, but you can have an understanding over here. Okay, I'm teaching you the introduction of CAD till now. Okay, CAD is known as modern epidemic nowadays. Why it is known as modern epidemic? I guess you got the introduction why CAD is happening. It is due to obstruction of the coronary. Okay, who is doing the obstruction? I will tell you in pathogenesis. First, you understand why CAD is known as modern epidemic. The other name given to CAD is modern epidemic because it is the leading cause of death in developed countries nowadays. It is the leading cause, one of the leading cause of death of developed countries. You can see 25% of the death, total death in the developed countries is due to CAD only. 1/4 of the total death is due to CAD. You can understand, out of the total 100% death, 25 to 30% is due to CAD alone. It's the leading cause of death in developed countries. That's why we call it a modern epidemic nowadays. Why the trend is increasing in developing countries? Nowadays in developing countries also the trend is increasing because of lifestyle changes. We are adopting modern culture, Western culture. Indians are adopting the Western culture, and nearly in India it is 15% of the all the death. India is a developing country, so you can say in developed country like US it is 25% of the all death, and in developing country like India it is 15% of all death. Okay, so but it is increasing. It is on increasing trend in developing countries also. So that is known as modern epidemic. Modern epidemic. So out of the total death, 25% of it is due to CAD in developed country, and out of the total death, 15% of which is due to CAD in developing country. I hope you got it. Okay, so we have seen the introduction. Now coming on the pathogenesis. Pathogenesis, you already understood why CAD happened, because of obstruction of coronary, because there is imbalance between demand and supply. If you are not fulfilling the demand, don't ask for supply. But you are not fulfilling the demand and asking for the supply, it will be imbalance leading to CAD. So I hope you got it. What is demand of the heart? What is supply of the heart? Demand of the heart is in the form of coronary blood. Supply of the heart is in the form of the blood which is coming in aorta because of contraction of the left ventricle. If you keep on giving the blood in the coronary, the heart keep on contracting and give the blood in the aorta. But if you obstruct the coronary, heart will stop pumping. The left ventricle will stop pumping and there will be less blood or no blood in the aorta. So that's the coronary artery disease. Got it? So what is the pathogenesis? The pathogenesis is there is a plaque formation in the coronary. Atherosclerotic plaque. Can you see the coronary? The purple color coronary. See, atherosclerotic plaque is formed and obstructing the coronary. Can you see? This is atherosclerotic plaque. You all can highlight it. This is the plaque in the lumen of the coronary. So atherosclerotic plaque formed in the lumen of the coronary artery. And this plaque convert into the thrombus. Thrombus will obstruct the lumen. Okay, so limiting the blood flow to the myocardium. Okay, so myocardium will not get the blood, especially the left ventricle myocardium will not get the blood. So it will not contract. If you're not giving the blood, it will not contract. Impairment of the heart function and less blood will come in aorta, and that's coronary artery disease. Okay, so you are giving less blood to the heart, to the left ventricle wall, especially because there is obstruction in the coronary. First atherosclerosis is there, that will convert into thrombus. So this is the lumen of coronary. First atherosclerotic plaque is there, then it will convert into thrombus. So it is obstructing the flow. It is obstructing the flow. So left ventricle wall will get less blood. And that's why it undergo ischemia and infarction. See the background yellow color. The background yellow color is ischemia and infarction in the wall. And that portion of the wall is non-functional, not contributing in the contraction in the systole. So left ventricle systole is very subtle or no systole at all. So no blood is coming in aorta. So none of the organ receives pure blood. And that's coronary artery disease. So this is the pathogenesis. I hope you all can write it. So what is happening? You are causing obstruction in the coronary artery. Appreciate the obstruction in the coronary artery. Appreciate the atherosclerotic plaque formed in the coronary artery, because of which the thrombus will form, and appreciate the obstruction in the lumen. Since you are obstructing the lumen of the coronary, the left ventricle wall, appreciate this is left ventricle wall. The left ventricle wall is not getting the proper blood. It is not. So it will not pump. It will not pump. So if it will not pump, the blood in the aorta will be limited, and that's coronary artery disease. So you can see this is demand and this is supply. If you are reducing the demand by causing obstruction in the lumen of the coronary, supply automatically decrease. So less blood will come in the aorta, and that's coronary artery disease, imbalance between demand and supply. I hope you all got it. So you got the introduction, you got the pathogenesis. But the most important in community medicine is to understand the risk factors of non-communicable disease. So please make a 5-star over the risk factors and the prevention. Okay, so risk factors. If you understand the risk factors, prevention is very easy. So what are the risk factors of coronary artery disease? We divide the risk factors in 2 categories. What are the 2 categories? Non-modifiable and modifiable. Non-modifiable risk factors and modifiable risk factors. You can see here we are having non-modifiable risk factors, and this side we are having, what do you mean by non-modifiable and modifiable? Non-modifiable, we cannot modify it. Even we wish, we cannot modify, but modified is in our hand. If we wish, it is modifiable. If we wish, we can modify. Here, even we wish, we cannot modify them. That's why they are known as non-modifiable. You will understand. So please learn. There are 4 non-modifiable and 13 modifiable. Total 17 risk factors at the tip of your tongue. The risk factors for coronary artery disease, you have to learn the number. Okay, 4 non-modifiable and 13 modifiable. Okay, so total 17 risk factors. One by one, we will see the detail. So let's start with the non-modifiable. There are 4 non-modifiable: age, gender, family history, and genetics. Now you can understand. Can you change your age? I wish we have the time machine, but no, we cannot change our age. That's why it's non-modifiable. Can you change the gender? Although the intergender surgeries are possible nowadays, but overall gender cannot be changed as it is without surgeries and all. Family history. I mean, the family history. Can you change your family? I mean, you are born in a family with the genes of the family, so it cannot be changed, and genes cannot be changed. So these all are non-modifiable risk factor. So let's take them one by one. You can appreciate the 4 non-modifiable risk factors: age, sex, family history, and genetics. So let's start with the age. Age. So CAD, don't forget what I'm teaching you. CAD, coronary artery disease. Coronary artery disease, CAD incidence increases with age. It is more common after 50 years of age. Maximum incidence is 50 to 60. Maximum incidence of 50 CAD, heart attacks, is 50 to 60 years. Maximum incidence 50 to 60 years. The second is gender. The incidence is more in male as compared to female. The incidence of CAD is more in male as compared to female. The third is the family history. It runs in the families. If the grandfather have the heart attack, there are chances the father will have, and there are chances the children will also have in the future. Okay. So it runs in the family. So it indicates there is some gene which is not yet detected, but maybe some gene genetic factor is there. And for genetic factors, one more thing, because of the genes, LDL level and cholesterol level will be affected. Because of the genes, various enzymes are formed, and these enzymes control the cholesterol and the LDL levels. Okay, so cholesterol and LDL levels are dependent on the genetic factors. So these are the 4 non-modifiable risk factors. What are the 4 non-modifiable risk factors? CAD. CAD increases with age. The incidence of CAD, coronary artery disease, increases with age. It is more common after 50 years of age, maximum 50 to 60 years, maximum incidence. It is more common in males as compared to females. That is gender. It runs in the families. And there are genes which control the amount of cholesterol and triglyceride in the world, in the blood. Okay, so these are the 4 non-modifiable risk factor. Let's start the modifiable risk factor. There are 13 modifiable risk factor. One by one we will see. Okay, now what do you mean by modifiable? Why they are known as modifiable? Because if we wish, we can modify them. For example, someone smoke, but if the person wish, person can quit the smoking. Someone is having high BP, but it can be controlled, it can be treated. Someone is having high cholesterol, high homocysteine, it can be controlled, it can be treated. Someone is having diabetes, obesity, it can be controlled. Physical activity, hormones, type A personality, alcohol can be quitted, soft water, noise can be avoided, drugs can be avoided. Okay, so they all are modifiable if wish. If wish is there, these are non-modifiable. If the person wish, I will be young again, I shall be young again, but the person cannot be young again, so this is non-modifiable. Here the gender cannot be changed. Okay, here the family cannot be changed, here the genes cannot be changed. They are non-modifiable. Now coming on modifiable one by one, let's start with smoking. Okay, CAD is directly proportional to smoking. It is directly proportional to smoking. It directly proportional to number and duration of smoke. There are 2 person, one person smoke 1 cigarette one day. Another person smoke 20 cigarettes one day. So obviously the risk is more in the second one. So it depends on the duration of smoking as well as the number and duration of the smoking. Okay, it increases synergistically with the hypertension. Smoking along with hypertension synergistically increases the risk of CAD. And even after quitting, the risk fall after years. Suppose this person we are counseling, no, you shouldn't smoke. If you are smoking, there is high risk you will have heart attack in future. You will have CAD in future. You should quit smoking. So this person have quitted. From today, the risk will not decline. It will take 5 to 10 years to decline the risk completely. And this person have same risk as that of non-smoker, but it take years even after quitting. Even after quitting, it takes few years. So that is smoking. Okay, why smoking increases the risk of CAD? Smoke contain 2 things, carbon monoxide and nicotine. So the smoke which the person is inhaling inside in the lungs, it contains 2 things, carbon monoxide and nicotine. Both are bad. Carbon monoxide causes atherosclerosis. It causes atherosclerosis in the coronary, narrowing the lumen of the coronary. And nicotine causing vasoconstriction. Vasoconstriction of the coronary, again narrowing the lumen of the coronary. And nicotine also increases myocardial oxygen demand. It increases myocardial oxygen demand. So because of all of which, it increases the CAD risk. You should know what carbon monoxide is doing and what nicotine is doing, and how both of them present in the smoke, they increases the risk of CAD. You should be able to explain this pathogenesis. So smoking. The second is hypertension. Increased BP. Hypertension increases the risk of atherosclerosis, and because of atherosclerosis there is CAD. I hope everyone got it. The main culprit in the CAD is due to atherosclerosis in the coronary artery. So anything who is causing atherosclerosis in the coronary artery obviously increasing the risk of CAD. So high BP increases the risk of atherosclerosis in the coronary leading to CAD. The next is serum cholesterol. Obviously, if cholesterol is more, atherosclerosis is more. If the serum cholesterol is more, atherosclerosis is more. If the cholesterol level is more than 220 milligram per deciliter, there is high risk of CAD in the future. Okay. There are two types of cholesterol, good cholesterol, bad cholesterol. LDL is bad and HDL is good. I guess everyone know this is LDL. LDL is atherogenic. It increases the risk of CAD. HDL is protective in nature. It protect the CAD by transporting the cholesterol to the liver. So blood levels will fall. Okay. LDL HDL ratio should be less than 5. If LDL HDL ratio is more than 5, if it is more than 5, it increases the risk. Dietary fiber reduces the risk, and apolipoprotein A1 and B are predictors of for LDL and HDL. So how much LDL I have in my blood, how much HDL I have in the blood, we can test it with apolipoprotein A1 and B. They are the indicators of HDL and LDL in the blood respectively. I guess everyone knows this. Okay, the next is homocysteine. Homocysteine level more than 15.5 causes damage to the intima of the artery. You know, the artery is having 3 layers, intima, media, and externa. You can see this is intima, this is media, this is externa. So anything who's damaging the intima increases the risk of atherosclerosis. If the intima is damaged, there are high chances there will be atherosclerotic plaque formed in the coronary. So if homocysteine is high, homocysteine damage the intima, and because of damaged intima, atherosclerosis will be high, and that will lead to CAD. This is the mechanism. Diabetes. The next is diabetes. The person who is diabetic have 3 times higher chance of developing CAD in future as compared to non-diabetic. So diabetes is an independent risk factor for the CAD. The next is obesity. Obesity increases the risk of hypertension, diabetes, and cholesterol. And all these 3 are independent risk factors for CAD. So obesity is a risk factor for CAD. The heart attacks are more common in the person who are obese as compared to the person who are normal weight. Okay, the next is physical inactivity. If the person is inactive, sedentary lifestyle, there are high chances this person will have CAD heart attack in future. But if the person is doing exercise regularly, the person is active, there are less chances. Why? Regular exercise increases good cholesterol. Okay, it reduces weight, it reduces BP, and that's why it reduces the chances of CAD. So the person who do the exercise, it increases LDL in the body. Okay, LDL will increase in the body, the good cholesterol will increase, the bad cholesterol, HDL will fall, HDL will increase, LDL will fall, and cholesterol will fall, BP will fall, and the person will have less chances of CAD. This is the reason why physical activity is good. Okay, the next is hormones. Estrogen. Estrogen carries a risk for CAD. Hyperestrogen. So the females who take OCPs for years, they are more prone of developing CAD in future. Hyperestrogen. Okay, estrogen increases the cholesterol in the blood. It increases the chances of CAD. The next is type A personality. You know who is type A personality? The person who are very competitive, they are very impatient, they are irritable. You know what is? It is a type of personality in psychiatry we study. There are various types. So type A personality are the people who are always stressful, they are tension, they are very competitive. Type A personality, they have increases chance of CAD. Okay, because of the stressful nature. Okay, the next is alcohol. So CAD chances are more in heavy drinkers. The person who drinks, they are chronic drinkers. The CAD chances, heart attack chances are more in them. The next is soft water. The person who drinks soft water for years and years. You know, soft water is a water in which the minerals are removed. Minerals are good for us. There are many minerals in the water. You know, zinc, magnesium. There are many minerals. They are good. They are protective in nature. But if the person is drinking soft water for years and years, that lack the protective salt and they have high chances of CAD in future. So it is one of the risk factors. The next is noise. You know, in high noise, if the person is exposed to high noise chronically, if the person is working at such an environment which is very noisy and constantly the noise is more than 110 decibel, it increases cholesterol and it increases atherosclerosis, and that's why it increases CAD. Okay, the last one is the drugs. There are certain drugs like fenfluramine or phantoramine. Phantoramine, these are the drugs that damages the heart, damages the coronary, causes atherosclerosis in the coronary, and that can cause the CAD, that increases the chances of CAD. So these are the 13 modifiable risk factors. Why they are known as modifiable? If the person wish, they all can be removed. If the person wish, smoking can be quitted, Hypertension can be controlled, cholesterol can be controlled, homocysteine can be controlled, diabetes, obesity, physical inactivity, they all can be controlled. Hormones, estrogen levels should be normal. Personality can be changed doing meditation, yoga. Alcohol should be quitted. Soft water should not be used chronically. Noise exposure should be less. And the drugs which causes CAD, having the high incidence of CAD, should be avoided for prolonged use. So they all are modifiable. So there are 4 non-modifiable and 13 modifiable, total 17 risk factors for CAD. These are the 13 modifiable one. What are the 13 modifiable one? Can we revise it quickly? What are the 13 modifiable risk factors for CAD? Smoking, diabetes, high cholesterol, homocysteine levels that damages the intima, diabetes, obesity, physical inactivity, OCP or hyperestrogenemia, type A personality, alcohol, soft water, noise more than 110 decibel chronically, and certain drugs like fenfluramine. These are the 13 risk factors, and you should be able to explain or draw the flow chart, or in short, you should be able to explain each of them, how they increases the risk of CAD. You don't have to mug up people. You have to learn the risk factors, but how they are causing CAD, you can explain by your own. So total 17 factors, 4 plus 13 in front of you. The 4 non-modifiable risk factors: age, gender, family, and genes. And the 13 modifiable risk factors. So total 17 risk factors. I taught you total 17, 4 plus 13 risk factors over here. So we are done with introduction. We are done with pathogenesis. The most important, we are done with risk factors. Now clinical factors of CAD. So let's come on clinical factors of CAD. Okay, what are the clinical factors? So CAD manifests as one of the 4 things. If coronary got obstructed, either the person have angina or MI, myocardial infarction is MI, or chronic ischemic heart disease, CIHD, or sudden cardiac death. Okay, so the person have one of the 4 things. If the coronary of any person get obstructed, there are 3 coronary. Maybe one of them is obstructed, 2 of them are obstructed, or all 3 are obstructed. It is known as triple disease. All 3 can be obstructed. Okay, so person have one of the 4. Either the person have angina, or the person have MI, or the person have chronic ischemic heart disease, or the person have sudden cardiac death. So here I will be explaining you the first 2 most common, the clinical features of angina and the clinical features of MI. So what are the clinical features of angina? Angina, the classical angina. Angina is also of 3 types, but here we will see the details of the classical angina. Classical angina, the person is having only one complaint: chest discomfort. Don't call it chest pain, call it chest discomfort. The person is having chest discomfort. Okay, why? And what is the difference between angina and MI? Does anyone know? I do not want to teach you pathology over here, but broadly you should know the difference between angina and MI. Angina pectoralis and myocardial infarction. In both of them, the coronary is having atherosclerosis. In both of them. Can you see the coronary? Appreciate the coronary. The coronary is having atherosclerosis. In angina, it's partial obstruction. If there is partial obstruction, so the left ventricular wall receives less blood. It is receiving less blood. Still, it is receiving some blood. So that less blood is sufficient to do the basal activity. The heart will pump less. Because you are giving less blood, the heart will pump less. And aorta will get less blood. And all the organs will receive less blood, because you are giving less blood to the coronary, because coronary is partially obstructed. Okay, but that less blood is sufficient for basal activity. If I'm sitting not doing anything, that much blood is sufficient for my organs. But if I start running, jogging, or doing any physical activity, so that much blood is not sufficient now. Okay, so person have chest pain only on exertion, not at rest. Okay, so that's angina. But in MI, there is complete obstruction of the coronary. The coronary is completely obstructed. So in angina, which I taught you previously, in angina, there is partial obstruction. The coronary is getting partially obstructed. So the left ventricular wall is receiving some blood, not complete blood. And that's why there is transient ischemia, not infarction. Transient ischemia is angina. But once you will obstruct the coronary completely, there is no blood at all, and the left ventricular wall undergo infarction. Can you see the background yellow color? That background yellow color is ischemia or infarction. If it is ischemia, call it angina pectoralis, because it's reversible. And if it is infarction, it's necrosis. It's irreversible. Call it MI. So the left ventricular wall, the background yellow color, the left ventricular wall, if coronary is partially obstructed, it undergo transient ischemia, and that leads to angina only on exertion, not at rest. And if it is completely obstructed, it undergo necrosis. Necrosis is irreversible death. That's infarction, and that leads to MI. I guess everyone understand these basics. Just for revising, I'm telling you. So what are the clinical features for angina and what is the clinical feature of MI? So angina is reversible. It's ischemia. But MI is irreversible. It's infarction. I hope you got it. So angina. First I'm teaching you the clinical features of angina. Then I will teach you the clinical features of infarction. Okay, MI. So angina may have patient have one complaint, that is chest discomfort. Chest discomfort only on exertion. You can see on exertion, on rest it will disappear. So chest exertion occurs on chest discomfort occurs on exertion, it disappears on rest. If the person is resting, there is no chest discomfort. If the person start running, jogging or any activity, the chest discomfort is there. Why I'm calling discomfort? It's not pain. The person say I'm having heaviness in the chest. I'm having some pressure feeling, squeezing, choking feeling in the chest. You know, someone is doing squeezing in the chest. It is known as Levine sign. The pain will last only for 2 to 5 minutes. Once the person rests, it will disappear. First, it will increase in intensity, then it will decrease in intensity. It is known as crescendo decrescendo pattern. The pain increase in intensity, then fall in intensity. It is just for 2 to 5 minutes. And after that, the pain disappear. Pain occurs on exertion. Pain disappear on rest. That is a typical feature of angina. What are the clinical features of MI? MI is also pain is there. There is no discomfort. The person actually have the pain. Which is sudden, very sudden pain, severe pain, crushing. It's crushing in nature. And it will, it will radiate to the arm and the back. It is radiating to arms, neck and back. Arms, neck and back, it is radiating. The person, because of the pain, the person have acidity, indigestion. Okay, the person goes in the shock. Okay, the left ventricle stop pumping at all. No blood in the aorta. None of the organ is receiving the blood. That's known as shock. The person will go in shock. Kidney is one of the organ. Kidney also do not receive the blood. If kidney do not receive the blood, oliguria. No urine. Oliguria. Okay. And all the blood will accumulate over here. Okay. Because it is not going ahead. The left ventricle is not pumping. So from left ventricle, the blood will go in the left atria. From the left atria, the blood will go in the pulmonary vein. And from the pulmonary vein, the blood will go in the lungs and accumulate in the lungs. And that is known as pulmonary edema. That will lead to dyspnea. Pulmonary edema is due to backflow of the blood and that will lead to edema. I guess everyone understand the pathology here. I'm not there to explain you the pathology. I hope you can see. You can see the left ventricle is not contracting or contracting very subtle. Okay, so that's MI. That's MI. You can appreciate this portion is infarcted. Okay, MI. Okay, so we have seen the clinical features. Okay, now the ultra important thing in CAD is the prevention of CAD. How to prevent it. You already know how to prevent. There are 4 levels of prevention. I have explained you. Primordial, primary, secondary and tertiary. You can see primordial, primary, secondary, tertiary. There are 4 levels of prevention. So out of which here we use 3 levels. Primordial, primary and secondary. Primordial prevention, primary prevention and secondary prevention for CAD. I'm teaching you prevention for CAD. One by one we will take. Let's start the primordial prevention. What is primordial? No need to revise again and again. Primordial, here we take the action before the risk factor arise. Before the risk factor arise. So what we can do? We can counsel the child to eliminate the risk factor in the future. This child don't do smoking, don't do alcohol, having a healthy diet. So we will say that yes, currently the risk factors are absent, but in future also avoid these risk factors. Okay, so focus on the children and the young people and discourage them for unhealthy lifestyle. Ask them don't smoke in future. Don't use alcohol. Don't use poor diet in the future. In future, you always use healthy diet. Okay, don't smoke, don't alcohol. So even before the risk factor appears, you are eliminating them. This is a primordial. Or you can use the mass approach. This is one-to-one approach. One-to-one. Father to child, mother to child, parents are to the child, one-to-one. This is known as mass approach. Show the same on the television. You go to watch some movie in the theaters. Before the movie starts, there are advertisements shown by the government. Smoking causes cancer. You may have seen that ad if you watch the movie in the theaters. Okay, so it is mass. On the television, we are showing that smoking causes cancer or no, smoking causes, alcohol causes coronary heart disease. So we can do mass. Mass counseling, mass education. So one-to-one or mass. Here, both of them is before the development of risk factor. Before the development of risk factor. That's why they are primordial. The next is primary. In primary, the risk factors are already present. But disease is absent. Disease yet not developed. Got it? That is primary prevention. Here also population strategy and high-risk strategy. Population strategy, we will give strategy for the whole population. Okay, and high-risk strategy, we will screen only the high-risk people. Okay, we will give the preventive measures only to the high-risk people, not the complete population. One by one, we will see there are two strategy, population and high-risk. Population strategy, it is directed towards the whole population. irrespective whether the risk factors are present or absent. The whole population, we will encourage the whole population to take a good diet, to take the saturated fats less than 10%. The saturated fats in the diet should be less than 10% in the complete diet. The cholesterol should be less than 300 milligram per day. In one day, don't eat cholesterol more than 300 milligram. Serum cholesterol should be less than 200 milligram. And there should be more carbohydrate or more fiber intake in the diet. So take a diet which contain less than 10% saturated salt, saturated fats, I mean. That diet that should contain less than 300 milligram of cholesterol per day. Okay, and increase the carbohydrate and increase the dietary fiber. So we will encourage the complete population. Okay, and we will ask the population to quit smoking. Okay, I mean, on the advertisement everywhere, aim a smoke-free society through education as well as legislation. You know, nowadays smoking is prohibited at public places. If anyone is smoking at the public places, the fine is there or some punishment is there, jail is there. So it is legislature, okay, or via educating the people. Blood pressure control should be there. Okay, and physical activity. We have to encourage the physical activity. This is done on complete population. Now, what is high risk strategy? First of all, find out the people who are at high risk. Which people are at high risk? Who are already having the hypertension, who already have the increased cholesterol, who already smoke, okay, who already have the family history of CAD, heart attack in their fathers and grandfathers or any family member. The female who already on OCP, okay, and the person who are diabetic. They are high risk people. They are high risk people. They already have the risk factor. So we will focus just on this population. We will not focus on the complete population. We are focusing on the population which is having. So it is saving our resources. Okay, either we are applying the strategy to complete population or we are applying the strategy to the people who have the high risk group, like the people who drink, the people who smoke, the people who are physically inactive, the people who have increased cholesterol, the female who take OCP, the people who are diabetic, like that. We are focusing just on that population. That is population strategy. Okay, so that the targeted population, selective population, we will treat the hypertension in them. We will ask them to smoke, to quit the smoking, and we will treat the cholesterol, hyperlipidemia in them. So that is primary prevention. Primordial prevention, we have taken the action before the development of risk factor. It's 1-to-1, that is parents to child, or it is mass approach. Okay, primary, here the risk factor is present, but the disease is absent. We are taking the action after the risk factor, but before the disease. So here we have population strategy or high risk strategy. Finally, secondary prevention. Secondary prevention, the disease already occurred, but disease is in an early stage. So we will do early diagnosis and treatment. Early diagnosis and treatment. Okay, so we will do early diagnosis and we will do the treatment. The treatment can be medical, the treatment can be surgical. Sometimes bypass surgery is required. Okay, the treatment can be medical, antihypertensive drug, anti-diabetic drug. So medical treatment or surgical treatment. We will treat it early diagnosis and early treatment. So we have 3 levels of prevention in CAD. Primordial may we treat the CAD. I'm teaching you CAD, by the way. Okay, the first NCD. Okay, the first non-communicable disease I started is CAD. So primordial may we take the action before the risk factor appears. Here we take the action after the risk factors. Here risk factor is absent, disease is also absent. Here risk factor is present, but disease is absent. Here risk factor is also present and disease is also present, but in early stage. I hope you're getting it. So here we have 1-to-1 approach like father to child and mass approach like television. Here we have population strategy, the complete population diet instructions, and high risk strategy. And here we are doing treatment, early diagnosis and treatment, surgical treatment or medical treatment, early diagnosis and treatment. I hope you got the first NCD. Okay, so if it is coming as a long question, you are well prepared how to write your answer. Don't forget to write the prevention. That is the most important thing in the university exam. You have to write the risk factors and prevention. So introduction, you write down the definition. It's an imbalance between demand and supply. Explain the demand, explain the supply. In the pathogenesis, write down it is due to atherosclerosis in the coronary lumen. How it is converting into thrombus and how it is obstructing, you can explain the flowchart. Risk factors, there are 17 risk factors. Okay, 4 of which are non-modifiable and 13 of which are modifiable. Each factor you have to explain in your own words how it is increasing the risk of CAD. Clinical features, you have to explain the clinical features of angina pectoralis and you have to explain the clinical features of MI. Okay, you can explain in your own words. Prevention, you have to write down primordial prevention, primary prevention, and secondary prevention. You should be able to explain it. Don't forget to divide the prevention into these headings. And you must understand what is primordial, what is primary, what is secondary. This is how you have to frame your answer in your university exam, and MCQs will be very easy from this portion. I guess you can understand. Okay, so in this session, I have covered 1 disease out of 7, The remaining 6 will be covered in the subsequent episode. Thank you so much. I hope you got it.